I would like to welcome all guest colleagues from Europe, US, and Japan who were able to attend the event in spite of these periods of unrest in our country. Our mission and contribution goes to our society in preventing the socio-economical burden resulting from blindness due to retinal diseases. As we all know, over 85% of visually impaired live in developing countries, and our target is to define the common causes of preventable blindness. Retinal diseases are very challenging. A lot of work ahead of us to recognize the best available know-how in diagnosis and treatment, and conveying our experience to all other colleagues. It's our responsibility to focus creating awareness of what our community deserves and need. We invite you all to share this memorable Rio encounter to be stimulating for everyone for future meetings. هستغل الفرصة إن احنا نحيي أسرة الراحل الأستاذ الدكتور علي المفتي، رائد من رواد جراحات الجسم الزجاجي والشبكية لسنوات طويلة، وكنا عملنا invitation لبروفيسور جاكسون كولمان, a friend of him. Unfortunately, he couldn't come, but he emailed us a nice communication in his memory. Sorry.
Hello, I'm Jackson Coleman, New York City, and I am very sorry that I cannot be there in person, but I'm delighted that I can. Hello, I'm Jackson Coleman, New York City, and I am very sorry that I cannot be there in person, but I'm delighted that I can be part of a program that is honoring Ali El-Mofty. Ali was taken from life too soon, but he made great accomplishments. He was a person whose life really mattered. We were fortunate to have him with us in 1977. At that time, he came over, spent a year with us here at Columbia, and worked both with Dr. Balazs and in my laboratory in ultrasound. He was studying vitreous and was interested in vitreoretinal surgery at that time. He left us the following year to go to Boston, where he worked with both Hal Freeman and Charles Skeppens, and stayed there for about 4 years. He had Moni, his wife, and his 2 children, and did a marvelous job in Boston. They asked him to stay, but he wanted to return to Egypt to be able to help bring some of the things they had learned back to Egypt, and he felt the need to return home. While he was in Boston, he had the opportunity to go to, both to go fishing with me and my son Jeremy here, but he had the opportunity to work with Hal Freeman, who was called to Washington to do retinal detachment surgery on Bruno Kreisky. This is a picture of Ali with his father. Ali came from a long family history of medicine. His father was a noted dermatologist. He had 3 uncles, all in medicine. He is named after one of them. His wife Moni is a rheumatologist, and his daughter is also a rheumatologist. And his son helped complete the completion of the Alnor Hospital. Anyway, as I was saying, while he was in Boston, Hal Freeman was called to Washington to operate on Bruno Kreisky, and that's where Ali developed a lifelong relationship with Mr. Kreisky. Kreisky helped set up foundations in Egypt that helped Ali not only develop fellowships for students, retina students and others to study both at home and abroad, but Kreisky also helped with the foundation that helped in the construction of part of the Al-Nur Hospital. That was a major accomplishment for Ali, and one that everyone should take great pride in having him accomplish. This is just Bruno, Ali, President Sadat, Mrs. Sadat, Mrs. Kreisky, and of course Moni. Today I'm going to talk to you about some of the technology advances that are taking place in ultrasound. We all know that optical coherent tomography has played a major role in advancing the treatment of macular disease, but ultrasound also is undergoing some major transformations in terms of the definition and resolution of various ocular problems. And what I'm going to present is work that is done here at the Harkness Eye Institute of Columbia by Dr. Silverman, Harriet Lloyd, and Suzanne Daly. And these are technologies that, unlike OCT, which as you see here, and all of you know, has magnificent resolution of the retina, and to some extent the choroid behind it in terms of thickness. But this resolution, particularly of such things as this lipid, does not allow for the definition of areas where light does not penetrate. An ultrasound, which for years has had a major impact on treating trauma, vitreous hemorrhage, foreign bodies, tumors, evaluating glaucoma, now with new technology has an even increasing role. And this is what I would like to discuss. I'm going to talk about 4 different technologies, particularly the wavelet, swept mode, annular rays, and chirp, and a sub technology. It's a harmonic technique that increases resolution and signal-to-noise ratio for looking at the choroid. Now this is an example of a 20 megahertz fundamental typical ultrasound of the back of the eye, showing the optic nerve with the meningeal sheath, little definition of the nerve itself, but by going to the first harmonic, 40 megahertz, you see how the definition is increased for the meningeal sheath and the optic nerve itself. Little finer resolution than we can get, and it's not the same as turning the gain down. It actually increases resolution from these structures. But let me show you some newer technologies that are even more impressive. This is an OCT, an older picture, but of an optic nerve head. I'm sorry, of a macular hole. And this is OCT. This is the 40 megahertz harmonic with a membrane attaching to the macular hole. And you can see the wavelet image, which shows that attachment of the vitreous even better, as well as showing drusen that are suggested in the harmonic image and in the OCT, but they absolutely shine, light up like trees in the wavelet image. Now, what is a wavelet image? You're all familiar with what is known as a Fourier transform that breaks sound down into various constituent frequencies. The wavelet also is a transform, but it breaks the sound down into constituent wavelets of different scales and positions in the time domain. And that time domain gives spatial localization that improves definition. Let me show you another example. This is wavelet imaging of the choroid, and this is the wavelet reconstruction. It's really a hybrid ultrasound. The information is taken from a routine B-scan, but with very intense processing of both the wavelet and of the time domain and constituent biomarkers, which I'll explain in a moment. We can get better definition of the ratio or relationship between fluid and the boundaries of cell walls. Notice how the pattern looks in this normal choroid compared to this abnormal choroid in wet AMD. The fluid boundaries are different, the tissue is thicker, even a drusen, which appears here, that's a retinal vessel appearing up there. So this hybrid picture is very useful in identifying the pattern changes that we see in the choroid. We also can see variations in the thickness by looking at the background area from the basic ultrasound. Now with this, we did a study of 69 eyes and 52 patients looking at roughly equivalent numbers of normal, dry AMD and wet AMD patients. And you can see that using one of these biomarkers, interscale phase consistency, we can get very clear-cut separation of these three different forms of choroidal change, change between normal and wet and dry AMD. If we do an ROC outline, we see a very nice curve that is, here it's 0.892, and other ones it was 0.89.5. This evaluation of just this wavelet classifier is, to me, proof positive that choroidal insufficiency or ischemia is often the base of all dry AMD. This does not mean that oxidative stress, genetic changes, and other features that we all know about aren't important, but choroidal ischemia may be a precursor to some of these defects that might be delayed with the proper medication. Now in dry AMD it's an ischemia, whereas it's a decreased homogeneity, whereas in wet AMD there's an increased homogeneity, and that can either be due to blood flow or inflammation, since we don't expect blood flow to increase in wet AMD or dry. It indicates inflammation, which others have demonstrated in wet AMD. Now again, if we look at that pattern that we see of the scatterers that outline the interstitial elements of the choroid, as you see here, the top, the normal, the bottom, the wet AMD, we can see that this change is marked. We can picture it with these hybrid ultrasounds, but just that one outline of the interscale phase consistency is able to demonstrate a separation of those three entities, dry, wet, and normal choroid. Now, what other techniques can we use to examine the choroid? One is called swept scan. And swept scan ultrasound is not Doppler, but we can actually get a color flow information like Doppler, and it's flow that can be accurately measured regardless of the transducer orientation. Doppler, as you know, would be able to measure vessels as they change and the fluid changes in line with the transducer. This allows us to look in the area, and with phase information we can see where the fluid with blood cells really are moving. And this looks at velocities, they're in the 100 micromillimeter range, and vessels that are 70 microns or greater. And this is truly quantitative. For example, this is an ultrasound of the front of the eye. This is the cornea. This is the iris. This is the iris root. And the arteriole seen here in a swept mode, here with the phase outlined, gives us a way of measuring flow or perfusion. This is another example. It's a patient with dry AMD. You can see flow in the retina. We can separate out the choroid. As you hear is just the pictures of the tissue of the choroid showing the vascular pulsations and movement. And this is with retinal and choroidal flow. Again, this is a swept mode analysis showing the region of the choroid, the retina, and with color outlining of the flow. And the type of color is a way of demonstrating whether flow, like in Doppler, is for the transducer or away from it, but more specifically, any dimensional flow to measure perfusion. And that's the real advantage of this technology. So we can demonstrate anatomic and flow changes in the human choroid following a drug such as sildenafil. Several people have already proposed that ischemia is the basis of dry AMD, like Friedman in Boston, Gene Grunwald in Philadelphia, but demonstrating how this concept can be used to treat patients, perhaps before they develop the retinal or pigment epithelial changes, could be useful. So we wanted to see if using a drug like sildenafil, niacin, other drugs, but particularly sildenafil, which is quite benign, whether it would be able to, benign in terms of ocular function, whether it would be able to increase flow. We had 7 patients, 14 eyes, all volunteers, and we measured the acuity, the digital very high frequency ultrasound, and we did the enhanced depth imaging, spectral domain OCT, and fluorescein on each of these young volunteers. Now there's one outlier. This is an abnormal pre-Viagra, and this might be related to the area that was looked at. It might have got an ampulla, but in all the rest of the patients, clearly there was an enhanced perfusion before and after Viagra, in each of these eyes, and this was an average increased perfusion of 3 times the baseline study. This is just a mean perfused pixel counts of the looking at the choroid, showing that there's about a 40% increase in perfusion. This is using the OCT to measure the thickness changes in right and left eyes, and both eyes showed an increase from the baseline. So increased thickness and increased perfusion can be demonstrated with with Viagra. This just demonstrates that there's a greater variation in the temporal retina and foveal retina as compared to the nasal retina. This was just looking at the location. So this gives us an indication that we can increase choroidal perfusion with a systemic drug, and at the moment we're studying a small off-label clinical series of patients with dry AMD prior to getting an IRB and doing it in a larger series. And we think that this may have, this significant increase in choroidal flow may play a role in delaying or perhaps arresting the onset of dry AMD to wet AMD. Now I'd like to talk about a better way of imaging the whole eye, and this is a technology called annular arrays. This technology was developed at Riverside Research Institute with Jeffrey Ketterling and Ron Silverman, and it essentially uses a transducer that is broken up into bands. And by exciting different bands and recording the delay in time coming back to the transducer as a receiver, there is actually synthetic focusing, which means that the lens is looking, or the transducer is acting like a concave lens. So by sequentially pulsing the rings, it simulates an optical concave lens of variable focus, and it provides significantly improved resolution. And this is an example. This is a 20 megahertz ultrasound annular array developed at Riverside and at here at Columbia. And this is the outline of the lens. This is the whole eye that can now be outlined with the synthetic focusing. And this, as you can see, compares very favorably to a surface coil MRI. This is one that was published by the Strengths in IOBS in 2004. And this, too, shows the whole eye and the relation of the ciliary body and ciliary processes. And now, with ultrasound and this annular array, we can essentially do the same thing. Now, what about CHIRP imaging? One of the areas that we really also like to evaluate is the vitreous. Now, in a patient that has had a vitreous hemorrhage, obviously we can't use OCT to advantage. This is a technique that uses a long pulse duration compared to a conventional short impulse, which traditionally gives us the best resolution, but it carries more energy without increasing the peak amplitude, and therefore it is safe to tissues. And then by using a technique that uses a time-inverted mismatch filter to bring back the image from this long chirp, and compared to the time duration of the chirp, we can get improved, a 10-fold improvement in signal-noise ratio looking at the vitreous. And this is a patient with a vitreous hemorrhage. The ultrasound now shows the vitreous in far more detail than we can get with routine ultrasound. You can see the hemorrhage layered at the back of the eye, the hemorrhage pooling in the retro solid vitreous compartment. You can see the membranes of the posterior hyaloid attached here to an optic nerve, as well as the detail of the vitreous, and again, the detail of the post-hyaloid in this patient with a hemorrhage. So you can see how useful this can be in evaluating vitreous hemorrhages, certainly in evaluating any case that has opacities where we can't use OCT or can't see, and again, more definition that we can get with routine ultrasound. So this is just one more patient showing the posterior vitreous cortex and the tertiary vitreous in a young female with optic nerve head drusen. That gives us, again, more detail of some of these physiologic states that we can get routinely. So what I've tried to show you is just different ways, the wavelet imaging, the swept mode, advanced pulse mode or chirp, and harmonic imaging that give us greater definition in looking at the vitreous, the choroid, not the retina, but certainly relationships that involve the retina. And all of these are new technologies that will be coming online in the very near future. So just to summarize, enhanced anterior segment ultrasound imaging gives us greater definition in the region behind the iris where the OCT isn't very helpful. We can see iris, or rather corneal planes better with ultrasound than even OCT can show. And finally, digital processing techniques give us definition of the choroid and flow in the choroid that other technologies can't. I'd like to say again that I'm sorry that I couldn't be with you for this very important meeting. I thank you for the opportunity to do honor to Ali Al-Mufti, someone who really made a difference to not only Egypt, but to the world. Thank you.
We are really indebted for Professor Coleman for his contribution and the memory of late Professor Ali Mufti. And we extend our thanks to him and to his family. So I wish to ask Professor Miller for his presentation for the keynote lecture.
Thank you very much. It's truly a pleasure to be back in Cairo, and I want to thank the organizer of the meeting for allowing me to speak at the Research Institute of Ophthalmology meeting. I'm going to speak on update regarding management of endophthalmitis, both treatment of as well as prevention. I do have these financial disclosures, none of which relate to my presentation. And I should indicate that I will be speaking about the use of antibiotics and corticosteroids inside the eye, which are all in an off-label fashion. None of these medications have ever been approved in the United States by the Food and Drug Administration for use inside the eye. But of course, we now have 30 plus years of experience to know that they are quite safe and effective. When we talk about risk of infection for cataract surgery, the risk ranges between 0.1 and 0.5%. There are several complications of cataract surgery which lead to a greater risk of infection, such as violation of the posterior capsule, or vitreous loss, or retained lens particles. When we do vitrectomy surgery, larger gauge sutured surgery, the risk of infection has been roughly less than 0.03%. About 10 years ago, when we switched to smaller gauge surgery, the risk of infection rose to as high as 1% because of difficulties with wound construction and leakage. When we paid attention to better control of our wound formation, the risk of infection has dropped back down to roughly 0.02%, very comparable to our previous 20 gauge surgery where we had our wounds that were sutured. We also today do many thousands of intravitreal injections. When these first started about 10 years ago, the risk of infection was as high as 1%, but today, recognizing the risk factors for infection, we've gotten that rate of infection down to roughly 0.05 to 0.1%. Lloyd Pauliello in 2004 and a group of investigators met in Philadelphia to define risk factors for infection, and I'll go over these very shortly throughout the course of my presentation. When we deal with infection, there still are a number of controversies. Vitrectomy versus vitreous tap, of course, was addressed in the endophthalmitis vitrectomy study almost 20 years ago, but still does remain somewhat controversial. We also still have choices in the use of intravitreal antibiotics. Do we use vancomycin, ceftazidime, or do we use one of the aminoglycosides, gentamicin or amikacin? The choice and role of intravenous antibiotics is still controversial. Years ago, of course, antibiotics weren't as effective, and when given systemically, the penetration inside the eye was not very great. But today we have much better agents, which I'll talk about once again. Corticosteroids used intravitreally were not part of the endophthalmitis vitrectomy study because it was quite controversial 20 years ago. Some centers felt that they were essential for a good outcome. Others felt they were not essential. This area still remains controversial. And finally, if a patient has systemic disease such as diabetes, they tend to fare much better with a more complete aggressive vitrectomy approach than with just a tap alone. But I'll talk about all these points throughout the course of my presentation. So the endophthalmitis vitrectomy study once again showed us now 20 years ago that if a patient has hand motion or better vision, they can fare equally well with vitrectomy versus tap. All eyes, of course, at intravitreal vancomycin and amikacin. But today, of course, we've gotten away from the use of the aminoglycosides and much more readily use vancomycin with ceftazidime. There was no apparent benefit from the use of systemic antibiotics, but once again, 20 years ago, the antibiotics did not penetrate well inside the eye when given orally or even intravenously. But today we have much better options, which we'll come to very shortly. The use of steroids, once again, was not part of the study 20 years ago. And today, the use of intravitreal corticosteroids still remains quite controversial and is dependent upon really the individual ophthalmologist as to whether or not he or she employs corticosteroids. So the first question we have to ask, are the results of the EVS still pertinent? A study done about 7 years ago showed that roughly only 1/3 of retina specialists still employ the recommendations because we've changed antibiotic management. And most of us now do a more aggressive approach with a vitrectomy rather than just a vitreous tap. The real indication for why the EVS was started 20 years ago was to try to save money, in that the taps were intended to be done in the office as an outpatient setting, but that never really happened. So I think that today we tend to be more aggressive with a vitrectomy and use a vitreous tap less commonly. My group has done quite a bit of work with the fluoroquinolone antibiotics, moxifloxacin and gadafloxacin. We have found that when these agents are administered orally, they penetrate inside the eye very readily, and most important, provide great coverage against the commonly encountered organisms that we see in most postoperative, blood-related, and even indolent chronic infections. We did research with gadafloxacin and moxifloxacin, and of course, several years ago, besifloxacin was also added as a possible alternative. In general, the fluoroquinolones have low serum binding, high bioavailability. They penetrate inside the eye in an excellent fashion when given orally, and most importantly, they encompass the most commonly encountered organisms that we see in postoperative infections. We also did similar work with moxifloxacin and found this was actually even a bit more effective when given orally. The penetration was somewhat better and provided a higher level of antibiotic inside the eye in comparison to gadafloxacin. Nothing comes risk-free. These antibiotics, of course, do have some potential complications. Uveitis syndrome has been recognized in a small number of patients. There's always the concern that there may be organism resistance. And just recently in the Journal of the American Medical Association, there was a small report indicating that there may be an increased risk of patients developing a retinal detachment on oral fluoroquinolones. This is yet to be proven, but it certainly raises that possibility. So how do we manage our patients? All patients, of course, have outpatient surgery. They have vitrectomy in most cases, or occasionally a vitreous tap. They receive vancomycin 1.0 milligrams and ceftazidime 2.25 milligrams intravitreally. They're sent home on over-the-counter topical fluoroquinolones, either moxifloxacin or gadafloxacin. And all of my patients receive a short 5 to 7 day course of systemic oral moxifloxacin, 400 milligrams per day. I see my patients back on post-op day 1, day 3 or 4, and in 1 week. And in general, patients do very well. I have not had a persistent infection that was not adequately treated for the last 7 or 8 years, but of course there are always complications of the infection process. Occasionally patients develop a retinal attachment or scar tissue, but in general this regimen very nicely treats the infections, the combination of the surgery, intravitreal antibiotics, and a short course of oral moxifloxacin. Our group also did work looking at whether or not we could deliver moxifloxacin intravitreally. We gave this to rodent eyes far exceeding the commonly encountered minimum inhibitory concentrations, or what's called the MIC90. We found that this was a very safe antibiotic when administered in the eye, even at very high levels. There were no signs of ERG toxicity, no signs of abnormalities in histopathology. But has moxifloxacin replaced vancomycin or ceftazidime? For the most part, the answer is no, but on occasion it certainly can be a very safe alternative. It's important to recognize that when we give antibiotics inside the eye, the half-life is very short. When we administer either vancomycin or in this case moxifloxacin, the half-life is less than 2 hours. So the drug clears very quickly. We therefore have to have adequate antibiotic in the eye for at least a half a day or so to treat infections. And this is why when we supplement with oral fluoroquinolones, it keeps the antibiotic level inside the eye very adequate for that first week or so to successfully treat most infections. If the antibiotic level exceeds the MIC90 for at least the first 12 hours, most infections can be very readily treated with our antibiotic regimens. And once again, the combination of the direct injection supplemented by the oral agents and topical agents can usually lead to a very successful outcome. We also looked at how readily the new fluoroquinolones penetrate inside the vitreous cavity. We gave these eye drops to patients undergoing elective vitrectomy surgery in non-inflamed settings in patients who were phakic, and we found that when we administer antibiotics quite frequently, every couple of hours for 3 days prior to elective surgery, we actually could achieve a reasonable level of antibiotic inside the vitreous cavity. But the antibiotics are only given 4 times a day for a couple of days prior to surgery. The vitreous penetration was virtually 0. So recognize that if you want the topical fluoroquinolones to reach the vitreous cavity in both patients, you have to give the antibiotic quite frequently. We put the antibiotic also in a cross-linked collagen shield, put this on the eyes for 12 hours prior to surgery, and really found that there was, once again, good penetration of antibiotic in the anterior chamber, but little or no drug in the vitreous cavity. So this brings us to the issue of intravitreal injections. We all recognize that we give thousands of injections every year, and in the United States, the injections have been given as an outpatient in the clinic since we started doing this now almost 10 or 11 years ago. When these were started, unfortunately, the risk of infection was as high as 1%, and so efforts were made, of course, to try to diminish that risk of infection. A group of experts were convened in Philadelphia in 2003, and some recommendations were brought forth in an attempt to lower the rate of infection. The main concern was this issue of the use of povidone iodine on the eye surface prior to delivery of the intravitreal injection. That is the most important factor in limiting the risk of infection. Other things that are generally done, of course, we use a speculum, we avoid direct touch to the eyelid, we avoid eye massage, etc. But far and away the most important factor that was agreed upon was the use of povidone iodine lid scrub prior to injection in an attempt to sterilize the eye surface. Areas that there were no consensus were issues such as the use of pre-injection or post-injection antibiotics. Most of us felt that this really didn't lead to any appreciable difference in the rate of infection, and today most of us no longer employ antibiotics topically either prior to or after injection. We just sterilize the eye with povidone iodine, do our injections, let the patient go home and see them back in a month at the time for their next injection. This area, of course, is still being debated, but once again, most of us do not use antibiotics in association with our injections. The one thing that has come out in a couple of studies, most recently by Colin McCannell at University of California, Los Angeles, is that it seems like most infections occur when patients or physicians are speaking and potentially contaminating the field. So we recommend that we don't talk or don't speak when we do our injections in an attempt to minimize the complications from our oral flora. Now we also deal with fungal infections. Voriconazole has really replaced our use of ketoconazole and or other agents such as amphotericin. This once again is an excellent agent that can be given orally or injected intravitreally, very well tolerated, taken up incredibly well by your retina as well as your liver, and the level of drug in the vitreous cavity is almost 40% of serum concentration within a matter of hours after administration. We gave this to rodent eyes once again to check for toxicity, and in this case we did find that when we exceeded 50 micrograms per ml, as you see on the slide on your right, there actually can be signs of retinal necrosis. So you have to be careful if you give this at too high of a level. You can induce retinal problems much like can be seen with amphotericin or even ketoconazole. But in general, this agent is much more readily tolerated and is very safe. We gave this to patients undergoing elective surgery, and we found that once again the penetration inside the eye was excellent, even in inflamed eyes. And when you give 400 milligrams orally, of course, you don't reach the level that you might see toxicity with. It's only if you give the drug directly into the vitreous cavity. Now, we have treated patients with this medication at 100 microgram injection levels. We now have 16 patients. None of them have signs of toxicity. And fortunately, all of them, even in cases that were non-responsive to amphotericin, have done well with eradication of their infection and no signs of toxicity. We also can formulate this drug topically. It has to be done, of course, with your local pharmacist. This is not available commercially, but we do give a 1% topical solution. Penetration in the aqueous, once again, is very good, but there's little or no penetration posteriorly when you give this agent topically. And once again, you have to have your pharmacy administer this, make up this solution, because this is not available commercially. So voriconazole in the treatment of fungal infections has really replaced my use of ketoconazole and or amphotericin. Very well tolerated, but if given at too high of a level intravitreally, you can cause retinal complications. We now have treated 16 patients with no signs of toxicity, giving them 100 micrograms of medication injected intravitreally. I mentioned at the start of my presentation that corticosteroids were not part of the endophthalmitis vitrectomy study. There's really no conclusive evidence that steroids are truly beneficial in the treatment of endophthalmitis. If we do employ steroids, we tend to give dexamethasone 400 micrograms in a single injection. There is some evidence that, depending upon the type of organism and or the timing of infection, the steroids may on occasion be beneficial. But if you ask me, do I use corticosteroids in my treatment of post-op infection? The answer is no, but it's really more my personal preference there's really no great data to support a true need for corticosteroids. I recognize that in select situations it may be helpful, but also in other cases it may be somewhat harmful, but once again, I generally do not employ steroids in my patients. What about traumatic cases? We published a number of papers on this in the past. You have to recognize, of course, that any infection potentially can be infectious. Open globe injuries have a 3 to 7% risk of infection. Retained intraocular foreign bodies, a 10 to 13% risk of infection. Sometimes the trauma itself can mask an early infection, but you tend to have much more virulent organisms in that things such as bacillus can cause very destructive effects in a very short period of time. So in most patients who have a traumatic injury, I don't employ antibiotics routinely, but of course if there's any sign of infection or in cases of organic matter contamination such as a farm type injury, soil type contamination, I will employ antibiotics, and I employ the same as I do in a post-operative setting. I employ vancomycin 1.0 milligrams and ceftazidime 2.25 milligrams and give my patients oral moxifloxacin 400 milligrams daily for the first 1 week. I just wanted to touch briefly upon the issue of prevention of infection in cataract surgery. A number of our cataract surgeons in the United States will employ antibiotics prophylactically. They used to use them in the infusion solution, but now more commonly inject cefuroxime in the aqueous. This, of course, is not routinely done, but this all started about 6 years ago when the European Society of Cataract and Refractive Surgery published a paper describing the use of intracameral cefuroxime, reporting a 5-fold decrease in the rate of postoperative endophthalmitis. This study was somewhat flawed, and the recommendations for this use of cefuroxime have never been widely utilized. Early on in the United States, roughly 6 to 20% of surgeons employed this. More recently, roughly half the surgeons in Europe, but even more recently, only about a third of the surgeons in Singapore employ cefuroxime on a routine basis. And I think for the most part, this is really, the recommendation is based on your particular wants or needs, but it's not something that's routinely done. Once again, the study was somewhat flawed. There was no great control arm. There is a lack of a commercial supply of cefuroxime. And of course, if you make a dilutional error, you can have problems such as a TAS or anterior segment toxicity syndrome, which can develop after use of cefuroxime. One other study I wanted to point out briefly was the use of topical moxifloxacin and or gadafloxacin in routine cataract surgery. This study done now 4 years ago described the fact that moxifloxacin topically may have a somewhat higher rate of postoperative infection. Now this study once again had 46,000 eyes, a big number of patients, but it's not really known if there's truly a difference in the rate of infection or suppressed infection, moxifloxacin versus gadafloxacin, but this certainly has never been really fully resolved. But just recognize this one paper that did suggest that moxifloxacin didn't control the rate of infection quite as readily as gadafloxacin. So when we talk about endophthalmitis, there have been significant advances made in the past 30 years. Most of the advances have been in the realm of new antimicrobial therapy, particularly the fluoroquinolones, moxifloxacin and gadafloxacin. No doubt that this work will continue. We'll have better, more effective agents in the future. Our lab, my wife's lab, is certainly working on better means of delivering antibiotics in a more prolonged fashion. And we certainly look forward to the day when our risk of infection is hopefully very, very close to zero. I want to thank you once again for the opportunity to partake in the conference. Look forward to meeting you throughout the course of the next 2 days. Thank you very much. Thank you.
Thank you, Professor Miller, for this valuable information, updating our regime for prevention and treatment of endophthalmitis. We are obliged to delay of 30 minutes of all coming sessions on communications. We wish you to understand that. That means that lunch break is from 1:30 to 2:30, and so we go with lunch with the experts. Now we call for the next symposia is Professor Amin El-Malati, Professor Rohrbach, please come to the podium.